This is a case study from my first clinical experience. The patient I selected was a 46-year-old male with a diagnosis of myalgia of auxiliary muscles, head and neck, right temporomandibular joint disorder, and other malaise. The patient was on several medications, including bupropion, which is a smoking cessation aid and antidepressant, atenolol, which is a beta blocker, which works to control high blood pressure, thiamazole, which is an antithyroid agent, which works to control hyperthyroidism. In an outpatient rehab facility, our past medical history is largely impacted by what the patient actually reports to us. So this patient came complaining of 3 years of right ear fullness since 2016. It was especially irritating to bend over and pick things up, and this movement could even be nauseating at times. If he slept on his right side, he would get a lot of congestion and be up all day long with fluid buildup in his sinus cavity. The patient reported that if he manipulated his earlobe, it would help open up his passages, but if he did it too much, that he would get more pain and nausea. The patient has been to multiple ENTs, and they all have said that the ears are clear, and he was even told that he might have temporomandibular joint disease. Or maybe it's muscle tension or a disc issue. They had no answers ultimately. Sometimes his hearing was muffled. The patient tried to make an appointment with the oral surgeon, but was also told that he would need at least 6 months of PT before being able to move forward within that process. The patient states that it feels like there's a tendon snapping. When chewing, there's postnasal drainage, and it feels like there's elastic bands in the right jaw joint. These symptoms were constant for him, and they altered his life. Something important to note in this case is that the patient just woke up with this feeling of it one day. He had been told by multiple specialists that everything looks normal, the tests and imaging came back negative, and so this patient is really desperate for answers and relief. The TMJ specialist had made a mouth guard, but it actually seems to worsen the symptoms. This patient operated his own business and was married with 2 young children, so he was really ready to get back to his regular everyday routine. The physical therapist exam summarized that the patient presented with limited range of motion and increased tissue bulk in the cervical region. Some of the tests performed included manual muscle testing of the cervical flexors and scapular retractors. The vertical opening of his jaw was 25 millimeters with a lateral deviation to the right, which was definitely decreased from the normal of 40 to 74 millimeters for males of vertical opening. And the range of motion included all cervical motions limited in all ranges. As a result of the exam findings, the PT diagnosis was atypical temporomandibular joint disorder on the right with ear fullness, moderate tension of the craniocervical musculature surrounding the right ear and jaw and into the cervical spine. Now I'd like to take a moment to pause and think, because I think most of you, like myself, are a bit unfamiliar with TMJ. So what is it? It's pain and limited movement of the jaw joint. Some of the common symptoms include difficulty chewing, a locking or clicking of the jaw, which for some patients can be extremely painful, overall jaw pain and tenderness of that area and the facial musculature surrounding it, and even ear fullness and pain in the ear. The temporomandibular joint, or TMJ, is a hinge and gliding joint, and it's one of the most commonly used joints in the body as we use it during talking and chewing. With TMJ patients, the disc often doesn't function the way it's supposed to and won't glide back and forth. Other structures involved with TMJ patients may include the temporalis muscle, the masseter muscle, which is our main chewing muscle, or the internal pterygoid. Many times with these patients, one or multiple of these muscles may be tight, or there's an imbalance when comparing left and right. Take a moment now to think about this question. What other structures would largely impact the symptoms experienced at the jaw? Now that we know a little bit more about TMJ, let's circle back to those goals. The physical therapist hoped to resolve symptoms 80% or better, increase range of motion for full cervical and jaw motions without pain. The patient should be independent with his home exercise program and maintain that status as a long-term goal. Also moving forward, there should be no symptoms with forward bending. The plan of care included the use of hot and cold packs, pulsed ultrasound to the right TMJ, therapeutic exercises, cervical range of motion and stretching, jaw range of motion, stretching, and stabilization, and for the manual therapy portion, which was a large focus in this particular outpatient clinic, included TMJ mobilizations, cervical mobilizations, and finger sweeps, which are performed on the inner cheek in order to release the internal pterygoid muscles. Some special considerations for this particular patient are that he had been coming for many years now, and he had tried any and all treatment options. He was beginning to feel discouraged and like they weren't making any progress until he started coming to PT. He didn't present with typical symptoms, which is why medical providers had such a difficult time diagnosing him. Our treatment consisted of a lot of trial and error, trying to target each individual symptom and assess the outcomes in that next visit. He was a great patient to have because he was willing to try anything. He often would come in with his own research, his own diagrams and pictures, trying to explain the exact area where his pain was located, or studies that he had seen to see if they would work for him. The patient was able to experience great relief, lasting for over a day sometimes, which was much more than he had previously had at only about an hour a day of relief. Some other considerations for this patient was that he had nearly an $80 copay. He was out of work because of this extreme pain that he was experiencing. So on top of the lack of work and the copay, there was a push to try to find relief for him in some way or shape as quickly as we could. Other issues were that the TMJ can present in a number of different ways across the board. So what we had usually seen with our TMJ patients was not what we saw with him. He didn't present with the typical locking or clicking, tightness with opening, or difficulty chewing. It was largely involving his ear and his neck. So we worked a lot to try to think outside the box and come up with new treatments specifically tailored for him. I chose to do my case study on this particular patient because I had never seen the treatment of TMJ before, let alone this unique case of it. It was interesting to see how the physical therapist and physical therapist assistant worked together collaboratively throughout the entire plan of care to get the best results in treatment for this patient. I loved being able to see the relief he experienced after suffering for so many years. This was another prime example of how what we see on paper is not what always physically presents in person. This patient was, in theory, going to be easy until we sat down and spoke with him more and had to really problem solve each individual issue. What we thought our plan was not at all our plan at the end of the plan of care. Thank you.